Thanks, and thank you very much for having me. I'm excited to be here, and I'm excited that we're not, I like debate formats, but I'm glad this isn't a debate, and I thank Dr. Somstein for that, too. I think that was a nice lead-in. In some ways, I'd like to invite him to Salt Lake to come see some Loop DS conversions from sleeve, because I do think it is a good way to go. It's a good option for the toolbox. Let's see. So disclosures, I added a little bit here. I don't have any financial disclosures. My partner, Dan Cottam, who does the bulk of our DS work, is part of the Speaker Bureau, not related necessarily to this for revisions. But then non-financially, I'm 9.5 years out from a sleeve gastrectomy, so I have skin in the game. And I first got interested in this at ASMBS when I was choosing sleeve, worried, like all of your patients are, that this wasn't going to work for me. It's worked great for 9.5 years. I still tell people I'm in an interim stage, okay? I'm not cured. I'm also a member of the Obesity Action Coalition and on the board, and that means I have a huge cohort of friends and colleagues who are also bariatric surgical patients. The OAC is there for everybody with obesity, but the practical matter is a lot of people in the OAC are surgical patients. The final is, for those of you who know and love Dan, I'm substituting for Dan here, but obviously not replacing him. My encyclopedic knowledge is, minimal. So apologies for that if you're expecting the Dan show today, which is awesome. So how do we get here? I'm going to talk more philosophically, especially late in the afternoon, than regurgitate a whole lot of data. First of all, Dr. Somstein just did a great job, I think, of putting the main data questions up there. And I don't want to talk too much about all the minutia of duodenal switch. But a lot of surgeons, it's popular these days to bemoan the weight regain or the inadequate weight loss of some patients with sleeve gastrectomy. And I really do think that we got to sleeve for a practical reason. I did several hundred lap bands because I had a lot of patients who would never even come in for a consult for a gastric bypass, right? And those patients, I've revised a lot of patients who had bands to something else, and most of them were happy to have had their band because they never would have had another tool. And I think we don't need to apologize for the sleeve. We need to say what it is, show what's in our toolbox, show our numbers, be transparent. We don't have to apologize for that. And the patients understand compromise. They understand that they may be not getting our absolute best weight loss or our absolute longest tool for everybody, and uncertainty is a part of life. So, but they really weren't buying what we were selling in some cases, and I think that's how we got the sleeve. We also, in Utah in particular, have been, I think, one of the longer states for having more than 30 years of a large gastric bypass program, and so maybe I'm a little more sensitive to some of those issues that come along, especially the weight regain. See, it's not uncommon for me to see a patient 15, 20 years out from a bypass who, lost 120 and has gained back 70. And they're not unhappy, but I think if they knew about DS then, if DS was available and it was a little more durable, and we don't know yet, I'm going to stipulate that. We don't have the long term, but we do have 4-year data coming out this year, even from the US. So, all right, well, again, we're all talking about the same thing in terms of failure. If we could put everybody on a genetic analyzer 20 years in the future, we'll know who's a PYY responder and a GLP-1 responder, who needs vagal, more vagal stimulation. I think Dr. Kaplan, it's really cool to see the work that they're doing in terms of medication responsiveness. So I really like this non-responder and responder language. Particularly, I think, as a surgeon, it was funny, when I was heavy, I could talk to people like, I understand you. But now that I've had great luck with the sleeve, I'm having to talk about it more as, I'm lucky. If you're not, it doesn't mean I'm living better. Follow me around for a day and you'll see. This early response thing, I think, is very cool as well. And still the patients get blamed. And this is the biggest problem to me for staging, is that your patients, if they're not prepared when they have their sleeve to come back and speak that language of, I'm not responding, if they blame themselves, which they will, I guarantee you some, but if they feel like you're a safe place to come back and say, I want to upgrade, then they'll show up at your door. Otherwise, they'll never come back. So I think this language needs to start ahead of sleeve. We all see people misbehaving, if you will. It's not a disease of naughtiness, but when you're hungry, you are gonna make bad food choices. And Dr. Sharma talks about this too, in terms of, never eat when you're hungry is what he says, but I think in translation it means never eat when you're starving. And a lot of people will go back into the boot camp mode, trying to trying to squeeze more out of the sleeves than they can get. The same way we've seen that with bands who will come back into your office 5 years later and want, the magic back. All right, so I also think we talked about the phenotype, that a lot of our data, and I really respect all the people who do the big research, we're still at the level of lumping our data and not splitting our data, and this is a diverse patient population. I think when we get the genetics, we'll see that a lot better than we do right now. All right, so surgeons, I talk a lot with patients about expectations. I think surgeons are looking for the perfect cure too. We talk about not curing it, but we really do want, we love that feeling with appendicitis that, you're not going to know my name a month from now. Goodbye, thank you. It's exciting. Clean data. Again, I think surgeons want clean data, and we sit up here, I think, sometimes trying to parse all these tea leaves of data and maybe ask more of the data than it can give us. So we can't go without data, but sometimes we can't ask it to predict more than describe. All right. I probably got the same slide up here 5 times. Dan told me to take a couple out. Same as Sam said, I think revisions by their nature are more variable, and that's going to make it harder for us to get good data. And so our art as well as science is going to have to be more artful. The same way we talk about cancer in particular. And somebody was talking about they subscribe to the one operation per lifetime issue with obesity, and I just I'm all for adding meds. I'm all for going back to the drawing board with the behavior, but to refuse to consider reoperation, I think, is impractical. All right, so a little bit of data in here. My slides are slightly out of order. So we did study this with Dan's patients, and I think Mitch, was in here too, Rosalind, looking at estimated weight loss between sleeve alone and Wasadi or loop duodenal switch. So better weight loss. And one thing about DS is you really are looking at more of an 18-month time horizon for weight loss. So we're following the Spanish lead on this. We do a little longer limb. That's really the only difference. If you look at 1 year weight loss, you're missing some of the weight loss that you get from duodenal ileostomy. It does not seem to be the abrupt drop that you get with sleeve or even bypass, which mostly run out of gas at about a year. So I'm sorry, back to the Utah here. So retrospective divided into 2 groups, and we're actually doing more planned stages than we used to. And I think a lot of patients are very receptive to that idea. And bottom line is it's pretty safe and it's pretty effective for either indication, whether you did an intended single stage sleeve, you came back later because the patient wanted more. And I think people adapt to that idea if they feel like you're a safe place to visit, to come in and see. You're then not going to be judged. So is there a benefit? I think so. I think that clearly, and this is where I'm not regurgitating the stuff that you guys have probably already seen from the DS literature, the diabetes control is superior. I don't want to say that bypass is bad, but it does seem to be more durable and more people actually off medications, even with the 300 centimeter limb, which I also want to acknowledge is not the classic DS. So we do need to prove that it has similar outcomes to the shorter limb DS. Patient satisfaction is excellent. We have been surprised at the stool changes. We have more patients with constipation as a problem than diarrhea. And then another benefit, I've seen a couple of cases of gastric cancers after remote bypasses. And if you do a loop DS and you get that 1% bile reflux, it's a 30-minute operation to go turn it into a Roux-Y. You're not shortening them that much. You maybe give them a 50 centimeter limb to get that. I wanted to quote the Pori's rule and honor the Pori's rule that, at some point we do have to stop operating before we kill people, but I don't think DS is that extreme. It has been held as extreme, and I'm on YouTube from 8 years ago saying it was, in my view at that time, too extreme. I think the SADI is that modification to make it safer. So I'm going to skip some of this. You don't have any gastric remnant. That's the one, Dan and I talk about this. The one place I would do, and I had a patient back in Duluth who had, I can't remember if it was ALS or Huntington's or something, where they were going to eventually need a G-tube, not be able to swallow. And their neurologist begged me to do a gastric bypass. I said, okay, gosh, I'm scared about the outcome. They're like, look, just help them get their life back. So I left room for a G-tube later. But the nice thing about doing sleeve over, this was part of the debate I was thinking. We were talking about sleeve versus bypass first. If you do bypasses first, you burned your bridges to upgrade. Patients understand when you tell them I can do an F250, a gastric bypass, I cannot upgrade that to an F350. And we really do, the DS is a stronger tool. But I can upgrade that sleeve quite nicely, quite easily. Virgin tissue, I did one a week ago yesterday. I am not a surgical superstar, and I am not a surgical, I won't say timid, but I'm definitely never known for my bravery. These do not bother me. I do not worry more about converting a sleeve to a duodenal loop. What bothered me was the ilioileostomy, doing that Y anastomosis down below in that fragile small bowel. So I was more scared of that. And I was more scared before I saw Dan do 200 dissections around the pylorus. It's not as bad as you think. I got a video I'm going to put out now that we're off embargo here on the web. It's really not a hard dissection. Where am I for time? I got a couple of minutes?
Oh, you got 4
Yeah,
minutes.
4 minutes, okay. Patients are scared of that adaptation. I think if we can help them get an expectation that it's a moving target. A lot of people want to figure it out at 3 months, 4 months after any operation and live the rest of their life that way. And I think you need to set them up that year 2, year 3, year 4 is just as much of a challenge, or a job change, or kid going to jail or whatever is going to set them back. So this is sort of my shout out from OAC as well, that shame and blame are real barriers to people seeking care. So you're going to see a lot of people who come in tears with their sleeve. Not too many, I hope, but I'm operating on more and more 25-year-olds. I'm sure you guys are as well, and I think it's okay to tell them that 60 years is a long time to expect something to work. And I wanted to throw this in there. This is probably a slide I should have thrown away, but I really loved Dr. Arya Sharma's description of the rubber band analogy. I'd never heard this before, and I like this idea for us as surgeons thinking that we're changing the set point. And Arya says nobody changes the set point. It's there. Surgically, what you're doing is you're changing the strength of the rubber band that's trying to pull you back to the set point. And we all do have patients, and I know people who say, I'm cured, and they stop pulling against that weight. And even with the strongest tool, if you're not pulling, you're going to regain weight. And I've seen that even with a couple of DS patients. I'm sure we all have, where patients feel like they should be fixed. So I'm going to start using this analogy more. I just learned it last week. And I think that also gives room for medications. It gives room for some reboot, but expectations. So practical. One of the things that practically kept me out of this, I told you guys the ilioileostomy scares me on a Roux YDS. The coding, I hear that more often than anything. Dr. Prashant in the General Surgery or the Bariatric Times article talked about this is an omega loop. If you really look at it classically, all you have done is a reduced service from a classic duodenal switch, because all you've done is shortened your operation by 20 or 30 minutes, depending on how fast you are. For Dan, it's 10 minutes. But you can always go back and correct that bowel reflux. You're really not doing a significantly different operation, and I shouldn't have thrown this in there. This is provocative, but the whole IRB debate, and I don't want to, dig in or be mean, but I do think that sometimes this is not as massive a variation to SOD or loop DSs as we. I don't know. Nobody ever made me do an IRB for switching between retrocolic to anticolic, or my anastomotic technique. So if you're new to DS, which a lot of people are, this is a truly tensionless anastomosis. I mean, we're doing the anastomosis basically almost under the belly button, practically. I mean, things just fall together. We don't cut omentum, probably not even 1 in 100 cases. Learning just where that gastroduodenal artery is a little tricky, but it's actually not hard to expose. And as general surgeons, the way we all trained, the only reason I ever went down there was for perforated ulcer or for cancer. It was always just a huge mess, and so I was scared to death of going in that area electively. But it's really, it does not keep me up at night, and I'm a guy who loses sleep sometimes. The suturing's much easier, and I re-explore a lot, and I've done a lot of gastric bypasses, and when I re-explore and see that jejunojejunectomy, that Y anastomosis, looking like a big bag, it looks very non-physiologic, and we all know we have patients with intermittent abdominal pain, and I just wonder what we're going to find out about, all this multiple divisions of that gut neurology. And it's nice not to divide the mesentery. Don't have the bleeding worry that you have with that. And we don't close the pseudo-Petersons or the Petersons, and have not had trouble with that. And I'm out of time. So just a shout out to patient-centered care. Patients are watching, and they're going to come in with hopefully good questions. And this is just my brag page. I'm very thankful. All you people and Jamie Foote saved my life in a lot of ways, or kept me out of a nursing home with a stroke. I had stroke-level hypertension, and I'm out there kicking butt, and I wish I was 20 pounds lighter. Okay? We all do. You know, this is worth evolving towards. I think everybody, I respect caution out of surgeons. I respect people not jumping on bandwagons too quickly. Don't be the last person to look at putting this into your, especially into your revisional toolbox, okay? You don't have to jump all over it, but that's my shout out to keep that upgradability in your patient population. You will be happy and your patients will be thankful, especially your 25-year-olds. You know, you can apologize to them 10 years from now if they regain weight after 3 kids, but then they've got the DS option. If you bypassed them, we're in a whole different world, right? Yeah.
Right.
Okay. Thank you very much.
Very much.